So today we will be talking about Adaptivo, which is a software that is proposed by Standard Imaging, and talking about Adaptivo and in particular the In Vivo module of that software. So I have no conflict of interest to declare. And to begin with, let's start with an overview of Adaptivo. So Adaptivo is a software that is composed of 3 modules. First, on the left, you have the pre-treatment module, okay, that uses the EPID without the patient to verify the accuracy of plan delivery. So it's a pre-treatment QA module. Then in the middle, you have the In Vivo module that uses the EPID in the presence of the patient. It does a daily exit dose monitoring using the EPID integrated image. So it's a predicted transit in vivo dosimetry module. And finally, on the right, you have the adaptive module. So the adaptive module computes cumulative dose reconstructions based on daily CBCTs. So the module has its own deformable registration algorithm and its own dose calculation algorithm. So with this module, you can have an independent offline daily computation of cumulative DVH or cumulative isodosis of your patient. What's very important about Adaptivo is that the software is capable of automatically importing your data from the RNV and automatically analyzing the data and send you alerts if needed. Today, in this webinar, we'll focus on the In Vivo module, so the predicted transit dosimetry module. So the In Vivo module has 2 modes. First, a relative mode that we will not be talking about today, in which each daily portal image can be compared to a reference image, typically the first fraction image, but you can change that in the software. And then we have the predicted mode that we will be talking about today. So as I said, it's a predicted transit dosimetry module. In that module, Adaptivo computes the expected exit dose signal and compares it to the actual integrated daily EPID images. The comparison can be done by both dose profiles comparison or global gamma index comparison. Currently, it's available for variant photons with flattening features only, and it's available for 3D CRT, IMRT, and VMAT techniques. So about the expected exit dose signal, how does the software compute it? So it just needs the DICOM CT, RT plan, and RT structure of the patient. That's what is automatically imported from your RNV. And it needs a few commissioning data that I will not talk about today, except that the measurements of those data will take you between 1 and 1.5 hours per energy. About the workflow of this In Vivo module. So it's a very simple workflow. So you start by doing your planning, and then there is the first treatment session in which you acquire your integrated EPID images for each treatment beam. Then it depends whether the DICOM discover is activated in Adaptivo. If it is, then Adaptivo will automatically search for new patients in the database and automatically retrieve the DICOM files from your RNV database. If it's not activated, then you have to manually import the data, but that's very simple. You just have to type the patient ID in the import window of Adaptivo. Once the data are retrieved, the calculations will start automatically, and it will last a few minutes. Once it's done, the analysis will be shown to the user. We'll see that on the next slides. And then you'll go on with the next treatment sessions with new integrated images, and the workflow of importing the data will start again. Once it's done, the software will compute weekly average and weekly reports, and of course, end of treatment reports. So this slide, just to say that the interface of Adaptivo is very user-friendly. So it's a web-based interface that you can access anywhere in your hospital. And it's very user-friendly because you can use the LDAP authentication that is compatible with Windows Active Directory. That means that you will use the same user and password than in your hospital network. You can customize and set up personalized email alerts, use custom workflows, and manage automatic reports that can be sent by email too. So this is the interface of Adaptivo. So that is the dashboard where you have your patients. For each patient, you have the plan, and for each plan, you have each treatment fraction. If the treatment fraction is correct, then the box will be shown green, and if it's not correct, then it will be red. So for example, we will click on this red box, so the fraction is not correct, and we have the detail of this fraction. So here you can see that it's a VMAT plan with 2 arcs. Here we have the default gamma pass rate that is shown, okay? And we can see that this arc is not correct. If we click on this arc, we have the detailed analysis of this arc. So, and in the detailed analysis, you have a hot and cold gamma map. So here we can see some cold points that are in blue. Below, we have the X and Y profile analysis. If we go below, we have the gamma statistics. So it shows you your gamma pass rate for various dose per stage and distance. So here we find our default gamma pass rates that we just saw on the previous slide. And below you have some gamma and those different histogram. So for us, it's a very simple and user-friendly interface. Our current practices in Metz is to use Adaptivo for now only for IMRT and VMAT. For 3D CRT, we still use our old diode measurement system. And as you saw it in the previous slide, we only acquire integrated portal images at the first treatment session. So if you want, we can discuss that in the question later. We also have variable gamma index criteria depending on a treatment location. So for head and neck or head treatment, we should have a mask for the positioning. So we used 3%, 3 millimeter, and the gamma pass rate should be superior to 95%, sorry. For breasts, we have 5%, 3 millimeter, and 90%. And other location, we have 5%, 3 millimeters, 95%. If the analysis should fade, then we'll have to investigate why it fails. So here in Metz, our workflow is to start the investigation by the patient positioning. So you could either look at the IGRT images or use the adaptive module of Adaptivo to have some idea of where and why it fails. Then we'll have a look at the LINAC failures. So typically we use a log analysis software to investigate for small deviations of the LINAC. So typically we can use the LINAC view software that is also proposed by standard imaging. And if everything is correct, we'll have a look at the plan in the TPS to search for possible deviation in the TPS. So let's start with the clinical example. So I have 4 examples. That's the first one. It's a head and neck treatment. Okay, a head and neck squamous cell carcinoma treated by 60 grays in 33 fractions, with an integrated boost. So it's VMAT treatment with 2 full arcs. We use daily IGRT with only 2 orthogonal KV images. And for the positioning, we use the 5 points head, neck, and shoulder mask. The problem with this case is that the patient was very stressed during the acquisition of the planning CT, and her shoulders were very tense. But in contrast, when we wanted to treat her, she was very relaxed and the shoulder positioning was not the same. That is the analysis with Adaptivo at the first fraction on the left. So it was not okay. You have the gamma pass rates here for each arc, and it was not okay even with higher criteria of 5%, 3 millimeters. And on the right, you have our daily IGRT KV image. And you can clearly see that the shoulder, the clavicle positioning is actually not correct. We did not see it because I think that our therapist was focusing on the spine positioning. So we did the treatment. It was not okay, so we programmed a second acquisition at the second fraction, and still it was not okay because of the clavicle positioning. Then we tried to work on that and correct the position in the treatment at the third fraction. So here you can see that the clavicle positioning is better and the gamma index was correct, more than 95%. So it was okay, but you can still see some hot points here behind the shoulders because we could improve the shoulder positioning, and that's what we did at the fourth fraction that you can see here, where the clavicle positioning is correct, and you can see that the gamma index is the gamma map are almost perfect. So I think that while we were focusing on the spine positioning, perhaps we wouldn't have seen that without the transit dosimetry analysis. I'll go on to a second clinical example. So it's a right breast that we treated using a conventional fractionation on 50 grays in 25 fractions. The technique was IMRT using 2 opposed tangential beams plus plus a skin flash. So skin flash is an option that you can use in Eclipse. The positioning, our positioning protocol for breast was daily light field positioning plus weekly EPID positioning. The patient was on the breastboard with a 2 points sheen mask for the positioning of the sheen. And the problem here was that the patient was tense when the therapists were present in the room. And then once they left the room, like 1 minute later, after the EPID positioning, actually, the patient relaxed and the breast positioning was not correct. So we will see that here. So here are the EPID positioning of the first fraction. So it looks correct. But when we acquire the integrated images, you can see here that the gamma index were not correct, like at all, okay? So we were wondering why, since it was okay. So we programmed a second acquisition at the second fraction, but still we had the same with our EPID image that is correct in the middle. But like 1 minute later, the patient had moved and the integrated images were not correct. So we had a discussion with the patient and we corrected that behavior. And then we saw that at the third fraction, after the discussion with the patient, she was relaxed before and after the presence of the therapist. And you can see that the gamma pass rate is almost perfect, like 100% on the left. And also the profile analysis on the right is also correct. So obviously without the use of the in vivo module, we would not have seen that again. A third clinical example, so again, it's a head and neck treatment, treated by 70 grays, 35 fractions, VMAT, daily IGRT with 2 kV images again, and the 5-point masks. The problem here was actually that the patient had a haircut between the planning CT and the first treatment fraction. We will see that. So here are the in vivo module analysis at the first fraction. So it was okay with 5%, but actually not okay with our criteria, 3%, 3 millimeters. And when we had a look at the gamma hot and cold map, we saw that the hot points were not really behind the shoulders. This is the bone comparison with the KV images. So it's not that good, but not that bad. So we had a discussion with the therapists to find out why it was not good. And we actually find out that the patient had a haircut, and this haircut was modifying the overall soft tissue positioning. That's when at this point, we decided to scan the patient again. So we had a new planning CT and replan the treatment. And these are the analyses that we had at the first fraction of the new plan, and you can see that it's almost perfect. So the problem was the haircut of the patient. And obviously, because the bone images are not that bad, I think that we would not have seen that without the in vivo module again. Finally, the last clinical example of today is a palliative spine treatment of 20 grays, 5 fractions, VMAT, daily IGRT with 2 kV images, and no specific positioning accessory. The problem here was that initially we had planned to treat this patient using 3D CRT, like 2 opposed anterior-posterior beams. And then we decided to use a VMAT technique to treat him. But we acquired at the beginning a simple 3D planning CT. And if we treat it by VMAT, we should have acquired a 4D scan that would have taken the respiratory motion into account. And we should have planned everything on the average intensity projection. So here are the results of the VMAT plan at the first fraction. And you can see that we have a huge underdosage in the inferior part of the lung. We were wondering why. So we planned a CBCT acquisition at the second fraction, and you can see that on the CBCT, so on the right of the slide, the densities in the inferior part of the lung are completely different than in our 3D scan that we acquire because we plan to use a 3D CRT treatment. So because of this density difference, the delivery of the plant was so different with this underdosage behind those high density structures. At this point, we decided to quickly replan the plan using 3D CRT for the last 4 fractions. And because I told you that for 3D CRT, we still use our old diode measurement system, I do not have the result to show you. But I think that without the in vivo module, we would not have acquired the CBCT for a palliative 20 gray treatment, and we would not have seen this problem for this patient. So in conclusion, I have to say that we are very satisfied of this module of the Adaptivo, so this in vivo module. We found it very effective to detect some of the patient-related treatment issues. And also it had major advantages. So the quick and easy commissioning, as I told you, 1 or 1.5 hours per energy. So the automatic retrieval of patients' data from the R&V is very effective and very important to save time for us. And it's highly user-friendly. During our initial tests, we found out that small LINAC-related deviations are difficult to detect because they are absorbed in the gamma index tolerances of 3% and 3 millimeters. And we found out that the LINAC should stop the beam if it detects a significant discrepancy, and that's why these small differences are absorbed in the gamma index. And we recommend, as we do, to combine Adaptivo with a log file analyzer to have these fine observations of the LINAC behavior every day. Thanks a lot